Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. If you are hearing this right now, then you are not currently a Journal Feed subscriber, and so you are not getting the full Journal Feed podcast. If you would like to get full access to both the podcast and the blog, then you'll have to become a member. All the details for that are at journalfeed.org. Now, this is the audio version of the past week summaries, which this week were brought to you by Shannon Marcus, Joshua Belfer, Vivian Lay, Jacob Atholz, Michael Stoker, and Clay Smith. Okay, let's get straight into the first article titled A New Legal Standard for Medical Malpractice Out of the JAMA. Now, something that is widely considered and thought about a lot in medicine in general is medical malpractice. Probably no place more than the United States, unfortunately. If there's somewhere more, I'd love to hear about it, but it's definitely a big concern in the United States. In America, it's just kind of a litigious society. Unfortunately, it's just the way that it's set up. And this makes doctors practice kind of defensive medicine. There's a lot of places that do this regardless, and there's a lot of variation between it, but it's just a fact. And there's a lot of doctors out there that kind of practice this way because it's always a consideration. You do something wrong, you hurt people, then, they're gonna they might sue you. And if that's the way the law works, then maybe the law can change. And there's potential for this, and clearly there's some people working on this. The American Law Institute is an organization that can put out advice about how the law should be structured. Each individual state in the United States can still make their own decisions, and they don't necessarily have to follow this advice, but they kind of tend to, and over time can adopt language which is first put out by the American Law Institute. It's kind of like putting out broad guidelines, and then each individual state can kind of get on board or not. And so here we have the American Law Institute putting out an update, a restatement of the major medical malpractice law and what they think it should be structured more like, which is a huge step in the right direction when you actually read some of this. This is really interesting stuff, and I really am very heartened to see how this works. A major update was a shift away from customary practice, which is sort of like what is everybody else doing, and more towards what is reasonable medical care. And this lets you incorporate evidence-based medicine into your practice so that this is now a defensible thing that you can do. I mean, it was always a defensible thing, but now it's what you're expected to do as long as you're providing reasonable medical care. And in line with this, the restatement really affirms that adherence to guidelines is sufficient to mean that you are giving good enough practice. But non-adherence to guidelines is not enough to establish negligence. Just like Ken Milne always said, they are guidelines. They're meant to guide your care and not dictate what you should do. And this wording is in line with that. And if this is in the law, then this really gives you more license as a physician to practice appropriately in your population and thinking what is most appropriate for your patient, and not just doing things because you're scared that you might get sued or because they're not exactly in line with guidelines that are out of date. There's also more language which incorporates the resources available to the provider. So if you're in a rural environment, now the law is more on your side to accommodate the fact that you don't necessarily have all the resources that anyone else would have. In terms of communication, now not just a choice between treatment or refusal, but now this gives more credit to informed decision making. And so you can make decisions with your patient, and that is a more structured thing, which is structured into the law and something you can expect to be doing with your patients, and you will not be faulted for this. All of this is in an effort to shift the risk management process away from the courtroom and to the bedside, where you can help people instead of just pointing fingers. If this was widely adopted, this would help a lot of people. This is huge. This would help a lot of physicians practice medicine the way that they want to practice medicine. And it would probably be best for their patients if we're not ordering tests that we're just doing defensively. It will take time in order for this to become the normal language of the land, but this is definitely a step in the right direction. I really applaud this. In a spoonful, this restatement of the standards of malpractice by the American Law Institute will likely be slow to incorporate, but sounds like a step in the right direction towards better patient care. And then the second article, titled Clinical Outcomes of Hypertonic Saline versus Mannitol Treatment Among Children with Traumatic Brain Injuries, out of the JAMA Network Open. Guidelines and evidence seem to slightly support hypertonic saline over mannitol, but neither should really be given with the expectation of improving neurological outcomes because they haven't really been shown to do that. However, they do lower the intracranial pressure, and that's what we want. It's local practice around where I work for neurosurgeons to give both at once. I've never actually seen anything that really supports that, though. I've never really done a deep dive on it, but it's not in the guidelines I've seen, and there's definitely a bit of evidence against it. Different mechanisms, though, between mannitol and hypertonic saline. I guess it kind of makes sense. You could double down and really get that intracranial pressure lower. I'd have to look into this. Anyways, the authors wanted to continue this time-old debate between the two, hypertonic saline and mannitol, but now in pediatrics, which of course it has been tested in before. Even though we already have guidelines on this kind of thing, and they currently support hypertonic saline over mannitol because it's a bit better at ICP control, but not because patient-centered outcomes are necessarily better. So what do the authors do? Of course, they make the outcomes something kind of sexy that we like to hear, neurological, intact survival, and mortality, even though we kind of already know that there's not a big difference and that neither of them even really seems to have these outcomes. So measuring them is probably not the best choice, but hey, that's what the people want to see, and that's how you get published in JAMA. So this was a large multi-center prospective cohort study which examined the use of 3% hypertonic saline against 20% mannitol in children with moderate to severe traumatic brain injuries. This was an observational trial, and so there's no randomization of these groups, but they did follow the patients and looked up whether they got one choice or the other, or even both, a total of 266 patients. Now, mortality was 7% in the hypertonic saline group and 11% in the mannitol group. That was a p-value of 0.3, and so that was not a statistically significant difference between the two. If you go into the supplemental figures, and I look at the group that got both hypertonic saline and mannitol, then after adjustments, this was still statistically higher mortality than getting either single agent, with worse neurological outcomes also. So it looks like giving both is not better than just giving one. So maybe we'll stick to one. Of course, we do not know why these physicians picked one agent over the other or both agents. You might suppose that the patient who was doing the worst is the patient that got both agents, and maybe they picked one over the other for particular reasons. This is an observational trial. We don't have that kind of granularity. However, we do have these kind of associations. Personally, I tend to favor hypertonic saline. There's a bunch of theoretical problems with mannitol. It could be nephrotoxic. It definitely causes diuresis, and I don't really want these patients to have less fluids in them. And generally, the data overall seems to show that hypertonic saline might be a smidge better. So I think I'm going to stick with hypertonic saline, and as we see observational trials like this, which don't really compare to the randomized control trial data, so I'm not sure why we do these trials in the first place, but people like to do trials. So here we have it. Regardless, this is just a quick reminder that if you like mannitol for some reason, or it's just what's available to you, you're probably not doing a lot of harm, and that grossly the two are largely equivalent. And we're not really looking for long-term outcomes from these agents, but they do lower the intracranial pressure. So we're accomplishing that. I like that. In a spoonful, this trial showed that hypertonic saline and mannitol performed similarly in this pediatric population, while giving both agents performed worse. Okay, that's the 5 articles and everything that we're covering from this week. Let's do a quick wrap-up of everything we talked about. From the first article, legal standards of medical malpractice are slowly evolving with the times. This should allow practice to evolve as well and hopefully prevent the practice of defensive medicine. From the second article, we saw data which supported the use of hypertonic saline or mannitol in the pediatric population with moderate to severe head injuries. Just don't give both of them. Again, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What were those articles about? Well, one talked about treating the partner of women with bacterial vaginosis. Another was a whole bunch of indications for hyperbaric oxygen therapy. And then lastly, when you get an ECG post-arrest in the pre-hospital setting and it's a STEMI, why is it usually different when they arrive to the hospital? Links to all the original articles can be found at journalfeed.org, or just follow the links in our show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.